I'm especially grateful to be here today to see so many familiar faces and also to share the stage in a spiritual way with Bill Keene, who I had the honor of hiring into the Oregon Health Division. And so he will be missed greatly, but the choice that you all have made to give him the Pump Handle Award is very, very well deserved. So I've been given the challenging task this morning of talking to you about healthcare reform and the practicing public health epidemiologist. And what I wanted to do today was to basically talk with you a little bit about some of the both opportunities and challenges that I think we are facing right now, sort of a sentinel time in our careers. Let's try this one. There we go. So how many people recognize this spot? That's good because it's on Mars. This is the Valley Marineris, and the reason I'm showing it is that this is actually the largest rift or chasm that's known to exist in our solar system. And I'm going to be talking in a little bit about another rift or chasm. That's not quite of this scale, but I wanted to give you this just to be thinking big. We have this opportunity of beginning to think about the healthcare system that we have in this country from both a public health and a clinical care perspective. And many people, including at least some in this room, but most of the folks I talk with or work with in my day-to-day life in Seattle, think of our healthcare system as this, the clinical and medical services delivery system that we have in this country. But actually, that's not the case. And I think that the true opportunity that we have with healthcare reform is to expand our notion of what a healthcare system is into a health system that includes not only clinical and medical services, but also the critical human and social services that people actually need to be healthy, the things that attack the underlying social determinants of health, like housing and chemical dependence and mental health services. And then finally, the things that many of us in our jobs perhaps care most about, which are the community health services, the population-based services, media campaigns to prevent tobacco use, restaurant inspections, et cetera. And I think as we think about our role in healthcare reform, it's critical to think about our role in all three of these domains. And that's what I want to talk with you about this morning. Because the reality is that that chasm I talked to you about is a chasm within our health system. I would argue strongly that the current state that we have in this country is that we have a healthcare delivery system that historically and currently primarily focuses on that first box, that clinical and medical services piece. And then we have a historically public health system that rests on focusing on that bottom piece, community health services. And in many jurisdictions, we really don't talk to each other very much. And in reality, the human and social services are kind of in a no man's land between both of these systems. We need to change this, and there's an opportunity in front of us from this current state to this future state, where rather than having systems that are split by a chasm, we instead are partners, public health partners and healthcare delivery partners that are working equally together across all three of these different domains. And I'd like to focus the rest of my presentation on some thoughts, some ideas, maybe try to get us all thinking a little bit on how we can make this happen and how we can, in fact, change that metaphor of a chasm to this metaphor, one of a zipper, where we are working side by side to make the right things happen. I need to say, I had a couple of other pictures of zippers to show for this slide, but my staff made me show this one. And I probably, in retrospect, thank them very much for that. So this is the idea. Let's walk through each of those three domains and think how we as public health partners can work with our healthcare partners in this zipper-like way to create a seamless health system in this country. And I wanted to put this slide in. This is a slide of the Holy Grail. We do not have it in Seattle, and that's my point. Somebody loaned this to me. I think they're from Minnesota, actually. But in thinking about how to talk about the nature of possible partnerships, obviously some of the examples I'm going to give you are from Seattle, because those are the examples I know. But they're really just examples, warts and all, to get us all thinking about how we can be doing this job better. So let's go to that first domain of clinical healthcare and think about how as epidemiologists we can enable better population-based access to quality, affordable care. As the public health partners in the system, this is what we should be thinking about doing. And this is actually something we've not done very well in the past. Historically, quite frankly, it's not been a major competency in many health partners, including public health epidemiologists. And historically, there's been limited availability on community-wide information on the access, quality, and cost of clinical services that are available to residents in the community. There are, quite frankly, at least in the past, potential vested interests of healthcare delivery partners in concealing some of the information about costs in particular and potentially quality. And the reality, again, is until recently there has been huge financial access problems in this country that have really dwarfed other concerns and have prevented us from making too much progress there. So in summary, I would sort of articulate or visually think in my mind that this is the situation that we have been in as far as public health epidemiologists thinking about how to better access epidemiologic information about clinical care. We know where to go, but we don't quite know how to get there, right? And let me take a step, and I know that, I think it was probably 5, 6, 7 years ago at CSTE, I did an unrelated talk, and there's a couple of these slides that I used in this talk. So those of you that were there before, I'm counting on you to be old, and therefore to either grant me some slack or forget that you've seen these slides before. But let's talk about then in clinical, just one example of how a health department can partner with the clinical care system to improve access to clinical care. And this was one I'm pulling from Seattle, and we really in Seattle, because of a community-wide interest, took the lead as the health department in trying to assure with the Medicaid expansion to take the lead in ensuring that people enrolled to that. This new financial coverage that we had available in our community really created an opportunity. And we worked very hard with our healthcare partners to catalyze a community-wide enrollment effort. We used existing partnerships. We keyed off the partnerships that both the healthcare system had and the public health system had to engage the human service organizations, bring them into the table. And we actually got a fair amount of business and political leadership in this as well. Kudos to the political leaders that we have in Seattle and King County, but they really stepped up and mobilized the community. And finally, as a small thing, we did try to develop a data-based approach to how it is that we approach this enrollment effort. And to my amazement, the media caught on to this. This was actually above the fold front page news in Seattle. It must have been a slow news day, talking about how we, the public health system, were going to be partnering with the clinical community system to develop a strategy that was data-based to reach the uninsured, basically by mapping where people without insurance live, mapping where we were enrolling people, and looking for where there were gaps between those two to, in real time, reallocate resources. And it worked. This is a slide that shows enrollment from October 1st of last year when it started through June of this year. And basically over that time period in Seattle and King County, we were able to enroll about 10% of our entire population who were uninsured into having new health care insurance, including blue at the bottom, which was the exchange, red, which was Medicaid newly eligible, and a little bit of a surprise to us, the green on this, are people that had always been eligible for Medicaid, but just hadn't realized that they were. So, and it's actually been, I don't have it because my epidemiologist told me I couldn't show it because the data were not robust enough yet, but it's really fun in BRFS to begin to watch how that rate of reported uninsurance has been dropping over the last couple of months. So it worked. And we did get a little bit of credit for it. This was a headline from, the last headline in the talk, but this was a headline in the paper from about 4 weeks ago where our safety net hospitals, the big one is Harborview in Seattle, are reporting substantially increased revenues as a result of the fact that an increased proportion of the people that they used to have to be providing health care for free are now coming in with insurance. So really pretty exciting stuff. And that's just to get you started thinking, but just as a couple of other places where a health department might be working in partnership with our clinical care system. One of the big issues we had in Seattle was people were worried, oh my God, what if we are successful? And what if we get all these new people to enroll? Is there actually going to be capacity in our primary care system to see those folks? And so again, in conjunction with our hospital systems, we did a mystery shopper survey, which is basically calling practitioners and not telling them you're from the health department and saying, are you seeing people on Medicaid? And if so, how long before I can get an appointment? And in December, before the people who were enrolling could be eligible, we found that about 45% of the providers in Seattle and King County were willing to accept Medicaid patients. And there was a great concern that that was going to be going down over time. Repeating the survey in April, actually it had increased to 50%. Great news for the policymakers and the public, and our clinical care colleagues, again, really appreciated this information. But what about waiting time? In December of 2013, when we asked, okay, how long to get an appointment, on average the time was 7 days, and in April, it was also 7 days. So an example of how very basic epidemiology can answer really important policy questions for the public. And I would put out for you in this domain that the door is open, but many of us are not taking advantage of the fact that there are now these all-payer databases that are being set up in many jurisdictions to look at issues of quality and cost of clinical care. That's a treasure trove of epidemiologic information, and I think your all's approaches in how to look at that would be a great benefit to your communities. And then the thing that all of us care about, but so much information recently on the extent to which our communities are experiencing disparities in healthcare. Again, another place where that's health department perspective on population-based, on community-based information can really potentially create a nice partnership with the clinical community. So that's domain number one, which is clinical care. I'm going to switch to the second one now, which is the human service arena. And y'all have seen slides like this before. Now I'm down in the South again, I can say y'all. Y'all have seen slides like this before, and this basically shows spending on healthcare by country, OECD countries on the left. The United States, of course, is on the top of that list. And on the right is life expectancy in those same countries. And of course, the United States is on the bottom of that list. We spend more than any other country on healthcare, and we have healthcare measures that put us at the bottom of the pack. But many of you, I suspect, have also seen this slide, and this was very telling to me. This shows that first slide, which says kind of, well, what's the problem with the healthcare system, really is misleading us. And instead, when you look at these same countries and you look at how much they're spending overall on healthcare and human services, once again, the US is an outlier, but it's an outlier in the other direction. We actually spend less total on healthcare and human services than many other countries. And when you look at the ratio of how much money the US spends on healthcare versus human services, that's really where we are the outlier, such as most of the world that knows what they're doing, for every dollar that's spent on healthcare, about $2 is spent on human services and preventive services. In the United States, for every dollar that's spent on healthcare, 90 cents is spent on human services. So the problem we have, arguably, in this country that's substantially contributing to our poor health outcomes is the fact that we are not linking people with the human services that they actually need to be healthy. And that is the second place where I think that we need to be working together, because historically, this thinking about human services has not really been a major competency of either public health or the healthcare delivery system. And I'd argue also that in many places in the country, the human service delivery system is siloed. And as a consequence, really has not been a good match with data-based approaches, in part because outcomes are difficult to define and measure, and we haven't done a lot of work there. And then finally, in part because I think collectively we all have been thinking that maybe it's somebody else's job to be worrying about this part of creating health in our country. So I'd encourage you all to think about, in your jobs, how is it that I might be able to contribute here? And just as a couple of examples to get you started, before we get there, though, this is my favorite slide. This is from Cambodia, actually. And for those of you that can't read this is a sign that says, "To this way," with an arrow, which is a great sign, right? Because you could put this sign down any place in the entire world, and it would still work for you. And the reason is because it provides absolutely no information at all. And I think in some ways, this, in my mind, is the summary of where we are with thinking about epidemiology and human services. We really haven't applied thinking here, and we have no information. Some places have, though. I see Lorene Mascola here. This is a slide from LA. And we've all talked about and are knowledgeable about in the healthcare delivery system, complex patients who consume healthcare and identifying those outliers and hotspotting them and targeting them with resources. In LA, they took this one step further and they said, well, actually, let's look at homeless folks, because homeless folks are complex patients not only in the healthcare arena, but also in the human service arena. And it turns out that that exact same dynamic happens there. If you divide homeless folks into deciles, which is along the bottom here, and then look at the amount of public resources they consume, the top decile of homeless patients in California took up over half of the public costs of providing care. And those public costs are part in blue, healthcare, but they're part in green and orange, human service and criminal justice care as well. And so we need to be expanding our notion of what we're thinking about when we think about service access and service delivery as we enter this new age. Here's a second example. This one happens to be from Seattle. We provide all of the care for the jail in Seattle. About 40,000 folks a year come through there. And this slide shows if you're in jail, the likelihood that you will not be coming back over a couple of years. And that top dotted line is the likelihood of not coming back if you have no mental health or chemical dependency diagnosis. There's about a 75% chance you will stay out of jail, a 25% chance you'll come back. Those two middle lines show the likelihood of you coming back if you have either a mental health or chemical dependency diagnosis. And there's about a 50% chance that you're going to wind up back in jail within a couple of years. And that bottom one is if you have both a mental health diagnosis and a chemical dependency diagnosis. And there basically we should give you a pass as you walk out the door because you're going to be coming right back in again. About 3/4 of all of those folks wind up back in jail. In my jurisdiction, about 80% of our budget, of the overall county budget, is directed towards the criminal justice system. And so that's a huge motivator for our policymakers of how can we do better here. And here's, I think, a classic example of saying one of the primary predictors of your budget is how well we are providing healthcare services, chemical dependency and mental health services to the people who are coming through this institution. It's really got their attention. And then finally, a third example, one of my favorite examples in Seattle is something we call global to local. And this is a public-private partnership that we've created where we use global health strategies that have been developed and proven for improving health in poorly resourced communities and trying to adapt and evolve them locally in our low-resourced neighborhoods. We've been fortunate to get this capitalized by our healthcare system, actually, who's put in $2.5 million into this right now. And the global health expertise is provided by a couple of local organizations we have in Seattle that know a lot about global health, so it's been really fun to work with them. One of those strategies, something that comes from the other parts of the world, is when you walk basically into a clinic and almost anywhere else in the world, people look at you and say, what's the array of services that you actually need to be healthy? That's not as common in this country. And so what we've done is create an ability in clinics in this low-income resourced area to basically have providers who are very busy, seeing patients every 10 minutes, write prescriptions for human services and allow people then have trained people, when somebody walks out the door of the clinic, they can give it to a social worker who's been trained to help them. And I just pulled, we're just starting this, so I haven't done the analysis as sophisticated as I would like, but I just pulled the numbers for last month to say, what are the issues that providers are actually seeing that are creating poor health in their patients? The top one, of course, is housing assistance. The second one is utilities assistance, because the last thing that you're not going to pay before you lose your home are your utilities. So that's a marker for people who are about to become homeless. Nutrition, food assistance, employment training, computer classes, clothing, legal, transportation services, job applications, English language, childcare, parenting classes. Things that all make sense to us, but at least true confessions, if you were to ask me about the epidemiology of need for these services in my jurisdiction, who actually is in need of transportation or education, or if you were asking about the epidemiology of where is that service available, I couldn't tell you. And so I think this is a challenge that we all have. If we really believe in the underlying determinants of health, we need to get off our butts and begin to think about how, from an epidemiologic perspective, we can partner with the healthcare system to know more about these services and make sure that the people who need them are getting them. Okay, last domain, and this is the one, of course, that we all probably have the most passion about, and that's epidemiology and the community health service piece of this. And I think it's fair to say that historically this has not been a major competency of our healthcare partners. And in fact, in many instances, perhaps they haven't been quite as interested in this as they should be. It's also probably fair to say that we've been under-resourced in this area so that the needs in the community outstrip public health's ability to provide them. Even in Seattle, there's an ambiguous political environment that makes it difficult sometimes for the government to step in and advocate for those changes in the community that are the ones that are actually the most important. And oftentimes we, public health, are siloed from those other key community partners that we need to be doing this work, the community development folks and the education folks. So I think we need to think about this one very carefully. Be deliberate in how we move forward to better engage our healthcare partners in how to partner here. And I think that one of the ways that we need to be articulating this is by better making the case for the importance of community on health. This is a slide from our colleagues in Seattle at the Institute for Health Metrics and Evaluation. They are Chris Murray's group. They are the world's experts on metrics for health. And basically what they've done on this slide is to plot life expectancy from 1950 to 2050, there's that line, in the 10 best performing countries in the entire world. And of course, the United States is not on that list because we are not one of the best performing countries. And the time this was done, the average in those best performing countries was almost 82 years. They then thought of an elegant way to say, so how far behind these countries are we, the United States? At the time this was done, the United States life expectancy was a little over 78. And if you back that up, you'll find that if today in this country we were to magically be able to start improving life expectancy at the rate of the 10 best performing countries in the world, it would take us as a country 16 years to get to where those best performing countries already are today. It's a bit sobering. But then they did something I think that was more elegant. They said this suggests a national problem and national solutions, but is that true? Let's do a thought experiment. Let's imagine that every county in this country were its own country and do exactly this same analysis. What would that map look like? And this is that map. And this shows that across the country, we have, of course, huge disparities, but those counties that are shown in blues are actually counties that are already at the level of the best performing countries in the world. And going down through shades of yellow to red, those counties that are in dark red are not 16 years behind, but rather up to 50 years behind the best performing countries in the world, such that if they were able to implement measures today to increase life expectancy at the rates that are the best in the world, it would take them 50 years to get to where the best performing countries are. And this really strongly suggests that the problem, while a national one, at its roots is regional, because that national average is being profoundly influenced by places that are performing poorly. So working with IHME, what we did was to take this one step further. You could look at this, and for those of you that know where Seattle is, we're one of those blue counties, and we could have said, oh, this is great, and good luck to those southeast counties, and right if you get work. But we said, no, let's take King County, and let's take every census tract in King County and imagine that every census tract were its own country. What would that map look like? And this is what that map looks like. That's Seattle in the middle of this. But basically, bottom line is that there is more variation by census tract within King County than there is county by country. And there are census tracts in King County that are dark blue that are up to 40 years ahead of the best performing countries in the world. And they are literally a 10-minute bicycle ride away from census tracts that are in red that are up to 60 years behind the best performing countries. So within walking distance, you can travel from an area that if that area were to start improving life expectancy at the best known rates in the world, it would take them 100 years to get to the place that you're walking to, and we'll get 5 minutes. We will get to in 5 minutes. Much too long to wait. This, I would articulate, is our collective challenge of the health system, and this is where we need to be better engaging our clinical partners. And it's quite amazing. So I've just altered this map a little bit. This is, again, census tracts in King County, and I split them up by decile, and basically shows that we have these profound disparities. But the thing that's just remarkable to me is that it doesn't matter what condition you look at. And so we've created this set of maps of the King County. Life expectancy in the top left is the one that you've seen. But reading across on the top, the next one is tobacco use, the next one is mental distress, adverse childhood experience is the one on the far right at the top, physical activity or lack of physical activity on the bottom left, obesity, diabetes, preventable hospitalizations. Every single map looks the same. Sure, it's the same in your jurisdiction, and this profoundly argues for the need for the clinical care system to raise its eyes from the people that are walking in through its door and look out to the communities that they are coming from, because it's those communities that are the ones that are actually producing the majority of poor health that they are now trapped in providing care for. Two thoughts on this. One, and if there's one takeaway from this, if you folks have not looked at the website for the Global Burden of Disease project that IHME does. The address is there, www.healthdata.org. Take a look at it. This is a work that's been done to look at creating a common metric, a DALY is what they've used, that allows for all-cause mortality to be compared to one another, a sophisticated methodology for handling missing data, which is a problem at the state and local level, and most importantly, rapid online state-of-the-art data visualization system that allows you, me, the public, policymakers to go in and ask any question about information for any country in the world and instantly have it be displayed up in a way that you can understand what it's saying. It's quite remarkable. Again, I would encourage you to look at it. And I would argue if this kind of thing can be done for Nigeria, it can be done for Nebraska, and it can be done for Nashville. And so what we need to be doing as a public health community is to say there are ways to get this information about health disparities, about what's going on in the community in front of the public, in front of policymakers, in front of our clinical providers, and we need to take the lead in making that happen for us to be successful. Because the reality is that what we need to be doing in the community is pretty common sense. But we're not going to be able to do it alone because we don't have the resources to do it. So we need to be tackling substandard housing. We need to be figuring out how to provide access to healthy food, about to improve clinic access in our poorest areas, about how to build in that infrastructure that allows for safety and for exercise, and how to deal with a myriad of social issues like density of alcohol and tobacco stores that create a lack of social cohesion. That is our challenge in the future, and that's what we need to be working to engage the clinical system in making happen. Now, I suspect that many of you see healthcare providers now and then, even though you're practicing prevention, and so are staying healthy. And when you walk in, we take it for granted, don't we, that there is going to be a medical chart that has all of your health information in it. And we would probably look crazily at a provider who says, oh, I don't believe in collecting or keeping information about you. There's some generic prescriptions, some of which may work for you. You take a scoopful as you walk out the door and come back in a year and maybe have some more. That'd be crazy. That is exactly what we do in public health, right? We do not have a standardized way of measuring and assessing the interventions that we are taking in our neighborhoods. And so the second concept for us all to be thinking about is, isn't it about time for us to acknowledge this deficit and begin to create a neighborhood health record for the neighborhoods and communities that we are serving? That would be this, just like an individual health record, a systematic, ongoing compilation of the health information that's needed. We can aggregate all of those great surveys that we do about individuals and create aggregated individual information, but we can also begin to include community characteristics in that as well that reflect the health of the community. And in this world of big data and real-time information, there's a huge opportunity here. We should no longer be hamstrung by the federal surveys that have guided our inability to produce local data in the past. So I put this out as a challenge to you. And I'm winding up, but can't stop without saying, all right, that sounds like it's going to cost money. How are we supposed to pay for all of that? And would put out to you that there are a number of opportunities that we are facing right now with our clinical partners for how to do this. Number one, New York's been a leader in this. We can expand the permissible use of Medicaid dollars into beginning to spend on some of these things that actually improve health. We can create shared savings where partnering with our clinical partners, if we can show savings over time to reinvest them back into these things that save health. Pay for success, social impact bonds, very hot right now. This is a place that, for example, Fresno is doing remarkable work on community health workers for asthma that they are paying for by private investors saying, this is going to save money, I'm going to invest in setting up this program, and I'm going to expect a return. Rikers Island Project on New York is another one. Huge opportunity here. New dedicated trust funds. Massachusetts is probably the best example of that at the state level. Obviously, we have the federal Public Health and Prevention Fund, which I won't say anything more about. But we could figure out how to do it better than the feds have done it at the state and local level. And thinking about how to mobilize these prevention funds, I think, is another way to think about spending. And then finally, hospital community benefit. As hospitals now have better alignment between what they want to do, which is create health, and what their business model is, which is to make money, they have to. We now have this opportunity to work with them to create these combined community health needs assessments. And more importantly, if we're looking all at the same community, the needs in that community are going to be the same, thinking about common investment strategies that involve real dollars from public health, from the community care system, and from our community development partners to actually make a difference. In closing, there's a little bit of urgency that I feel about this that I wanted to share with you, and I got this from looking at in more detail at some of those maps that I was showing you sort of at 3 a.m. when I was sleepless one night. And really, what we all know, right, is that risk factors predict outcomes. And so in diabetes, physical activity arguably is at the beginning of the chain, leads to increased risk for obesity, leads to increased risk for diabetes, leads to increased risk for diabetes deaths. And this is a generational cycle, and this is many, many years between those. But let me show you the maps now from King County, working in reverse order. This is our current map that shows diabetes deaths. This is our current map that shows diabetes. This is our current map that shows obesity, and this is our current map that shows physical activity. What this says is that in the absence of action today on physical activity, we are in essence dooming our children, the next generation, to that same map for diabetes deaths because of the lag between when we make our interventions and when we're going to see outcomes change as a result of it. So my closing thought to you is not to be depressed by that, but to recognize that while we maybe should have started working 20 years ago on this, the next best time to work on this is today, and I would encourage all of us to say this is not an insolvable problem. Actually, it's quite solvable. We have a new opportunity to do it, and this is the time to start on that. So in summary, healthcare reform provides a unique opportunity to us to become better partners with our clinical colleagues. It has the potential actually to redefine this partnership. And if you think about it, epidemiologic opportunities abound across the domain of clinical and medical services, human and social services, and community and health services. I'd argue that clinical services could benefit from a population-based approach to access, quality, and cost. Social services could benefit from an epidemiologic approach, period. And healthcare partners may be better engaged in community health if we can better provide them with the timely, comparable, and more granular neighborhood level data that they need for action. Seize the day. Thank you very much.